My name is Peter Forsberg. I'm an assistant professor at the University of Colorado. I'm a plasma cell disorders specialist, so I'm excited to learn about lymphoid malignancies from our wonderful panel of experts today. We really have a world-class group of providers here to share information on a number of interesting cases. So I'll ask them to introduce themselves. Dr. Pagel.
I'm John Pagel. I am not a plasma cell specialist. I actually focus on lymphoid malignancies, really exclusively do research and, of course, patient care in lymphomas and CLL, and I'm at the Swedish Cancer Institute in Seattle, Washington.
Hi, I'm Michael Thurman. Thank you very much for inviting me to participate in this tumor board. I'm on the faculty at the University of Chicago, and I specialize in lymphoid and myeloid malignancies.
Pleasure to be here again. Thank you. I'm David Schuster, and I'm a radiologist. I'm Division Director of Nuclear Medicine at Emory University in Atlanta.
So this is a 54-year-old male with relapsed high-grade B-cell lymphoma with involvement to the brain. Fortunately, less than 1 year after diagnosis, a patient was initially noted to have MYC and BCL2 rearrangements and now presenting for salvage therapy. So the question will be, what is the recommended strategy in this patient? So the patient was diagnosed with stage 4 high-grade B-cell lymphoma in early 2020. Now at this point in time, in early 2021, they're presenting in the setting of a seizure at home. They had noted mild memory deficits and fatigue, no vision changes, fevers, night sweats, weight loss, or pain, somewhat reduced performance status of ECOG-2 currently. Patient with no significant other past medical, social, or family history. In terms of their onc history in a bit more detail, in early 2020, diagnosed with stage 4 high-grade B-cell lymphoma with a large mesenteric mass, as well as testicular osseous extensive marrow involvement. Biopsy of the mesenteric mass demonstrated a high-grade B-cell lymphoma positive for CD20, CD10, BCL2, negative for CD30. FISH was positive for MYC and BCL2 rearrangements. Ki-67 was 75%, GCB by Hans criteria. At that time, MRI brain and CSF sampling were negative. So they received 6 cycles of dose-adjusted EPOCH-R with 8 doses of intrathecal methotrexate and radiation to bilateral testicles for a total of 30 gray. Interim and end of treatment PET scans showed complete metabolic responses. So now in early 2021, unfortunately, in the setting of this seizure, we have an MRI brain, which I'll let Dr. Schuster discuss results.
If we turn to the MR brain, we could see the lesion enhancing with edema in the left parietal region. And of course, this patient is at high risk for CNS involvement. It's noted that the PET was negative. Again, it may or may not have covered this area, or that there's so much intensity with the brain normally physiologically. If you didn't know lesions there, it may be difficult to see. I think the take-home message is that no other lesions were detected on PET in the body.
So in terms of current labs, white blood cell count is 2100, hemoglobin 10.1, platelets 145,000, so all somewhat reduced. Normal renal and liver function, LDH is within normal limits. Transthoracic echo and pulmonary function tests were normal. So in this patient with, now primary CNS relapse, a year after initial treatment with dose-adjusted DA-R-EPOCH, with intrathecal methotrexate and radiation to the bilateral testicles. Now we're dealing with this relapse. So Dr. Pagel, I'll let you, go first in terms of thinking what your recommended treatment strategy might be.
Yeah, you're certainly not making the cases easy, and this one is not easy for us. This is just in and of itself from the start a difficult case because of the biology. As everyone knows, a double hit or triple hit, those patients have extremely poor outcomes, even with very, very aggressive therapy. But not everyone. We do cure a good number of these people. And so we're going to strive towards curative intent. I think the dose-adjusted DA-R-EPOCH was the right thing to do. They're really the one subset of patients where we still believe that may be a superior regimen in R-CHOP for large cell lymphoma. Everything else is probably more still R-CHOP. We do, unfortunately, see these people relapse. And these kind of relapses in the brain are not completely uncommon. I guess it's an isolated relapse. I don't really remember the age of the patient or the comorbidities, but I'm going to try to get this patient's disease under control very quickly. And I'm going to give this patient likely high-dose methotrexate. That high-dose methotrexate, of course, has to be combined with leucovorin rescue. It has to be done by, experienced treating physicians and a team monitoring urine output and alkalizing the urine, but it's something, of course, that can be done. I try to get at least 3 to 3.5 grams per meter squared of the methotrexate in a patient. Certainly you need that kind of dose to get penetration. And I'm going to give this patient, a handful of cycles and see how they do. The longer-term plan for this patient is even more controversial. To get this patient into a remission, do you transplant this patient or not? Or do you do some intensive consolidation with a cytarabine-based regimen? Or do you just observe this patient? I think those things all come into a case-by-case discussion for each individual patient based on their comorbidities and goals of care. Often I would probably transplant this patient if I could after getting good disease control with high-dose methotrexate. Michael, do you have thoughts on this case?
Well, I agree with everything you just said. I think, this is a very aggressive lymphoma. I think, he was treated aggressively and appropriately up front. And, unfortunately, even with the most aggressive regimens in double hit lymphoma, we do see relapses. It's possible that this is an isolated CNS relapse, that this was a sanctuary site and that this is his only site that escaped the initial therapy. I think the best approach is high-dose methotrexate for him, and I agree. I would give him several cycles and see how he does. And then, again, depending on performance status, is he a good candidate for high-dose chemotherapy and autologous stem cell transplant? If he is, I think that would be a reasonable way to go. And then, a discussion with the radiotherapist whether or not they think that this area should be radiated after the completion of chemotherapy. I think there's a risk for toxicity with doing that. So I would prefer the high-dose methotrexate and assess response and potentially go for autologous stem cell transplant if the performance status is good and the CNS lesion responds well.
So, to summarize, unfortunately, a challenging case, of a patient who has aggressive disease biology, treated aggressively, now with a relapse with a primary CNS lesion. So consensus is to start with high-dose methotrexate-based therapy for at least a few cycles to try to achieve a response, followed by, if the patient is fit enough, strong consideration of autologous stem cell transplant to consolidate response and hopefully improve long-term outcome. Alternatively, could consider a cytarabine-based consolidation approach, but favor the transplant as long as the patient is a candidate, and maybe a discussion with the radiation therapist about potential role for that, but favoring methotrexate is the key to the initial part of the therapeutic approach.